Hi everyone, it's Friday, which means Facebook Friday in our private discussion group. It's lovely to see you all. I can see quite a lot of you have already joined in watching. So, as usual, we'll be doing these at least through the COVID-19 um, intense situation that we're all living through, and we wanted to make sure that we were giving you up to date and really clear information as soon as we got it. Um, but also just a really good opportunity for me, I guess, to tell you what's coming across my desk in terms of questions that people are asking me, knowing that if one person's asking the question, it's highly likely that lots of people also have the same question and might like to know what I say on the answer. Um, so, uh, COVID-19, let's get on with it because last time I yabbered on for ages and I'm trying to be a bit more concise. Um, a couple of things to say about COVID-19. There's not a lot of new information that has come through this week. However, there was a journal article that was published, which I think I did talk about last week, which is it's for health professionals. So it's in the Medical Journal of Australia, managing haematology and oncology patients during the COVID-19 pandemic, and it was a consensus guidelines. The patient summary of that is now available. Um, and the link to both that journal article and the patient information on the COVID-19 section of our website. So that's been updated. And it's not essential that you read that, but for some people, if you're the sort of person where lots of information helps you to manage anxiety and feel calm, then that's your place to go. Now, the actual article is full of big words and really complicated concepts. You're welcome to read it. Lots of you will probably get it because you've been living with this for a long time and you know how to navigate that kind of information. But the patient summary is really the one to have a look at. So that's there. And the other thing I would just say is that they are in the process of publishing an updated version of that. So these things are moving really fast. We're learning more all the time. And as soon as those updated versions of both the actual journal article, but we're also producing a patient summary information sheet. The updated version will be current on our website. So I'll try and let you know when those become available. So that's the first thing. The other thing we talked about last week was immunosuppression and the fact that not every person with NETs would be considered to be immunosuppressed. I was actually having a conversation with an infectious diseases doctor called Dr. Pat Charles. That's someone to watch out for, and I might see if I can stick a link to him on our Facebook group because he's been a really interesting source of very up-to-date and evidence-based information that's quite easy to understand. And often my measure is, well, if I can understand it easily, then probably most people can because that's the level I'm usually working at. But I had a conversation with him about immunosuppression, knowing that because COVID-19 is a novel virus, it means that nobody in the community has natural immunity from it. That means that boosting or being worried about your immune system in terms of catching the disease is probably a bit less relevant because we're all very vulnerable to catching COVID-19. The severity of COVID-19 depends on a couple of things, it seems, and we'll know more, and it may be that this information becomes out of date very fast. But the first thing is the dose at which you receive the virus. So there's a couple of fragments of virus on a supermarket trolley and you happen to rub your nose or I happen to rub my nose and I get a little bit of virus in my body, that's seemingly less likely to make me really sick as opposed to if someone coughed in my face and they were very sick with the COVID-19. So that's the first thing to say is it seems to be viral load seems to be quite important with how sick people get. So if I get a lot of virus straight away, my body's going to have to fight harder. And that's why we think health professionals are really struggling a lot with this because, you know, you can imagine if you're working in an intensive care unit and we've got people who are really sick, they'll be coughing and spluttering in the health professionals' faces and they're going to get a big dose of that virus. But the other thing is, of course, the way our body responds to that virus once it's on board, and that's where immunosuppression really plays a part. So for people who are on chemotherapy, people who have recently had PRRT and their bone marrow might be a bit suppressed, people who are having radiotherapy and the same thing might be happening, or having had recent surgery and your body's working a lot harder to repair that surgical damage, or other people who are frail. So being elderly, certainly your immune system's not going to be as good. Other chronic diseases. So, for example, my daughter has celiac disease. She's got reduced spleen function, so she's immunosuppressed. So for those sorts of people, it's not that you're more likely to catch the disease or the virus, but it may be much more likely that you get really sick with it, and sick for quicker and sick for longer and be infectious for longer because your body's not clearing that virus out as fast. But the other thing is that if you became sick with it and needed to go to hospital, you would be also more likely to pick up the other things, the bugs that hang around hospitals that we try so hard to control. But unfortunately, there are other bugs that do, like superbugs and that sort of thing, that do lurk around hospitals. So you're more vulnerable in the hospital as well. So I hope that helps kind of clarify that, because I was curious about it and I asked him and it was really helpful. So it was Dr. Patrick Charles. I'll make a note to put that on the Facebook group. The other thing I was just going to say is thanks everyone for the lovely feedback. If I say, it's my homework to put this piece of information on the Facebook group, if you know that piece of information, you're welcome to pop it up. I think we're all a team here, and we very much appreciate the way that you all step in and share information with each other, and also volunteer. For example, Denise and Katie, who help run this Facebook group, and without people like all of you, really, there's no way that we could get all of the information out to everyone. So yeah, if you know Dr. Patrick Charles and you can find a link to his Facebook page, stick it up in the group space before I get a chance. I'll be thanking you forever. The other thing I wanted to just talk about COVID-19 is just a bit of an update about the home injection service. There's been quite a lot of conversation on the Facebook group about that, as well as some conversations that I've been having with the drug companies who fund those services. So just to quick refresh, Lanreotide, the home injection service, is Assist Beyond, and they normally aim to provide some nurse visits in the home, or or to a clinic, or where whoever's giving that injection, to train the person to giving their own injection or having someone inject them. Sandostatin LAR has the eShine program. That is actually a home injection service, so they provide a health professional, either a GP or a nurse, who's had that training, to come into the home and provide that injection. The first thing I would say is that we've had reassurances about a steady supply of drugs, so we've got no problems at the moment, no concerns that we would run out of those drugs in Australia. The second thing is that both drug companies have provided to me the extra training and information they're giving to their staff around infection control in the home. So, one person actually was a group that we were I was talking with on Wednesday night, our Perth support group, and they were saying, well, gosh, is it more risk for us having someone, health professional, come into our home? They're getting a lot of extra, the health professionals providing the services have had extra training, and they're being provided with extra PPE, so that if they are if there's a risk there, they can be using that equipment. Certainly if a health professional is not well, they are not going into people's homes, but also people, if you're unwell and expecting a home injection person, you need to let them know, and they'll actually be getting in touch with you before they come to make sure that you are well, because the last thing we want is to have anyone spread this around any more than we absolutely can avoid. So we've talked about cleanliness, and actually also, I guess, in terms of levels of risk, having one person who's, very carefully washed their hands and is well in your home, as opposed to going and sitting in a GP clinic or walking through a front foyer of a hospital where we don't really have control over who else is in the environment and how well they are, or how clean they've been, how careful they've been. It's probably less of a risk. So just to reiterate what I said last week, if you're not enrolled in a home injection service and you'd like to be, I'm really happy to give you information about how to access that. And there's been some conversations today on the Facebook group about how to do that too. So the information's out there, but let me know if you can't find it. The other thing I was going to say is that for people who I was talking with the guy who runs the Assist Beyond program, which is about training people to really, get to a point where they're injecting their own lanreotide or having someone close to them inject their own lanreotide. They can actually do that training and the support online. So if you really don't want someone in your house and you're on that drug and you're thinking, oh, maybe I'll self-inject, I'll give it a go, you can actually still do like a Zoom type consultation with a trainer, a nurse who is trained to train people how to do that. So if you can still get a bit of support, even if you don't really want to have someone in your home. So that's just another thing to add. Okay. Oh, record time. It's only 10 minutes. Okay, so I wanted to talk, this has been on my list for a couple of weeks. I wanted to talk a bit about grade and stage because I know this trips people up hugely. So the first thing I'm going to talk about is grade, and then I'm going to quickly talk about stage. Grade talks about how similar our tumour cells are to normal cells. So we probably know lots of this, but I'm going to sort of go back to basic biology and just say that neuroendocrine cancer cells grow from neuroendocrine cells. So we've all got neuroendocrine cells in our body that help our body tick over, and the way they do that is to produce hormones. So the cells in my pancreas, for example, will know that after, when I've had some food, they need to produce enzymes that help me break that food down and digest it and absorb it so that my body will function well. My cells in my small bowel, when I've had some food, will produce some serotonin to help my bowel squeeze that food through. Otherwise, it's going to sit there like an uncomfortable lump. Neuroendocrine cancer is when there's been a mutation in a neuroendocrine cell, and you've got them everywhere from your brain to your bum, all through your digestive system, through your lungs, through all of the other parts of your body that produce hormones, essentially. Now, if there's been a mutation in a cell, it might only be a very small or a minor mutation, in which case we call that a low-grade neuroendocrine cancer, or a grade 1. So when we look at those cells under the microscope, they certainly are clearly, they've got a mutation, there's some changes in those cells, and they're growing out of control, have the potential to spread, but they still are very readily identifiable as neuroendocrine cells. Grade 2, the mutation's a little bit bigger or a bit more kind of major. They look a bit less like neuroendocrine normal cells, and they look weirder. So there's sometimes you'll see those cells that have like 2 nuclei instead of 1 nucleus. So those sort of really important critical things that make that cell into a neuroendocrine cell, they've kind of changed. They've really forgotten what they were supposed to look like in the first place. And then we've got the grade 3 neuroendocrine tumours, and that's where they look really different to normal neuroendocrine cells. And the reason I'm talking about this is that it really helps us understand about the receptors that we have, these home injections and all that sort of thing, and PRRT, that all target these receptors. So the receptors that normal neuroendocrine cells have on them are called somatostatin receptors. And sometimes you can think about it like a bit of a porthole or a doorway or a window or like a lock that needs a key. So normal neuroendocrine cells have that on them, and it means that when I eat my food, the body gives those cells messages to say, yep, time, Kate, to squirt out some hormones. So it's like the messenger system for those cells. Low-grade cells, because they're actually quite similar to normal neuroendocrine cells, have lots of those receptors on them. And grade 2 tumours, so they're a bit more different, but they often still will have quite a lot of receptors on them, which means that for grade 1 and grade 2 tumours, the somatostatin analogue injections that we use will plug into those receptors on those tumour cells. And it does 2 things. It stops those cells from being able to produce so much hormone, because it kind of switches them off and makes them think, no, nothing to do here. I don't need to do anything. I'll just go to sleep. But the other thing is that it stops the tumour from making new tumour cells. So that's also inhibits tumour growth. And it can do that. Usually doesn't do it forever, but I've got people who have been stable on these injections for 7 or 8 years, haven't needed any other treatment. Tumours are remaining stable. grade 3 tumours sometimes have those somatostatin receptors on them, but it's less likely because they've really changed a lot. They're really very different from normal cells. And so for those cells, because they're reproducing and making new cells really fast, they actually respond better to other treatments. So the true treatments that we use more in those high-grade tumours are chemotherapy. This chemotherapy targets cells that are making new cells really fast. And also external beam radiotherapy can sometimes be used in those situations, as well as things like targeted therapy, liver-directed therapy, which is when we're really sort of zapping a tumour in the spot where it is, that kind of thing. So look, it is complicated. I'm just trying to think if, oh yeah, and also, sorry, I knew there was something else I was going to say about that, which was around PRRT. So PRRT uses a peptide, a protein that fits into that little porthole or fits into that lock and key, just like the somatostatin analog, but that's been made radioactive. So for patients having PRRT, what happens is that peptide that's been made radioactive goes into the cell, into the cancer cell, and gives it a minute dose of radiation from the inside out. It's like a Trojan horse. It's really clever, and I get a bit excited, which is really daggy, but I actually think it's such a clever treatment because it's like a somatostatin analog injection, but not only does it kind of block that receptor up, it actually delivers radiation at the same time. So it's like an extra boost of that treatment, and that we know is a really effective treatment as well for people. We've known for a long time that that's been very effective for lower grade tumours. Interestingly, there's some really good trials coming on board to look at when we can use that treatment if it is effective for people with higher grade tumours, because we know some of those people still do have the receptors, and if kind of stands to reason that if you've got the receptors on your tumours, it should respond. So that's what they're sort of, I guess, the current research is looking at the moment. So that's what I wanted to talk about grade about. The other thing about that I wanted to mention was stage. So they're two numbering systems and they're really similar. Grade is talking about how similar those tumour cells are to normal cells. Stage is just talking, it's just describing whereabouts in your body they are. So there's a variety of staging sort of systems, but usually people will go to stage 1, stage 2, stage 3 and stage 4. So if you look these up online, there's heaps of explanations. I'm actually looking at a website called WebMD because that just gave me a really simple explanation. So stage 1 is when the cancer is small and only in one area. And, I know that some people, it's actually really common to get stage 1 neuroendocrine cancer in the appendix, and they do an appendicectomy, take the appendix out and realise that there's actually a tumour on the appendix, but it's not anywhere else. They look at the lymph nodes, they look at the size of that tumour, and they can make a fairly confident determination that's a stage 1 neuroendocrine cancer. And actually the prognosis, if we get those out nice and early, there's no spread, the prognosis for that is actually really good. So people, whatever sort of cancer they have, will need some care, but the monitoring and things in that situation are really minimal. So stage 2 and stage 3 are similar, and it's, I guess, a question of extent. So stage 2 means the cancer is a bit larger and it's grown into nearby tissues or lymph nodes. So again, if you've had an operation for a neuroendocrine tumour, but they've found that it's gone to the local lymph nodes, that means it's either stage 2 or stage 3, depending on the size and the number of the lymph nodes. Stage 4 is where the cancer spread to somewhere else in your body. So a lot of people with NETs, that's your liver, or it might be your lungs or your bone, or sometimes people do have other lumps just in their abdominal cavity or in their chest cavity. So that's considered to be stage 4. I think the really important thing that I would want to emphasize about stage 4 neuroendocrine cancer is that it is really different from, say, stage 4 bowel cancer or stage 4 breast cancer, where although it is improving with those cancers too, but certainly traditionally we were really, we would class those as kind of terminal, or where they're not curable. And I guess the important thing is that even if something is not technically curable, doesn't mean it's not controllable. So, and I wanted to tell you that the person who I've got on my books who was diagnosed, the earliest that I know of with stage 4 was diagnosed in 1984. So that it just tells us that actually, even though this cancer can be, kind of spread to other areas of the body, it does not mean by any stretch of the imagination that it is always dire. It varies from person to person, and I know for anybody, NETs is a very serious diagnosis, and it takes a lot of getting your head around. But I think it's really important that we hear these positive stories. We hear these stories where people have gone, well, I was told to get ready for something really quite awful, and actually, it's still been very awful, but not as awful as maybe it could have been. And there is hope. So always be with any of these sorts of things, be directed by your health professional, be directed by your doctor. Sometimes with NETs, it's really hard to tell early on how it's going to behave. And I often tell people it's a bit like saying you've got a dog. You might get a dog, but is it a really, really lazy spaniel, or is it like an Australian Terrier that might be, zooming around and digging lots of holes and creating havoc? So it's about working out what sort of dog you've got. But then you might have 3 Australian Terriers. I'm saying Australian Terriers because I had one when I was a kid. But, you might have 3 Australian Terriers all in a yard, and one is yapping and jumping over the fence. The other one is digging holes. The other one is trying to pull all of the pot plants out of the, So they're all going to behave in slightly different ways. And this sort of early start of getting established with NETs is often around getting to know what's the personality of your cancer, which sounds really weird, but it is. The doctors, and often the scans will be fairly close together at the start while we get a handle on, well, how's this going to behave in you? Each tumour is different, each body is different, each person's response to treatment is different. So it's going to be a lot of kind of waiting and seeing, which is really tough. So very quickly, alcohol and lemon juice came up on the Facebook this morning. So the first thing is alcohol. Now, always talk with your doctor. Some people find that alcohol contributes to carcinoid syndrome. So that's the flushing and diarrhea. Australian Silky Terriers are the best. Love you, Drew. We can have a bit of an Australian Silky Terrier fan club afterwards. But so alcohol, you need to talk with your doctor. Sometimes for some people, they find that their body doesn't tolerate it, even if they're being told that it's okay to have it. Sometimes people will say, well, I know I'm going to get a hot flush, but I'm choosing to have half a glass of wine anyway because, damn it, it's my birthday. And that's your choice. Always talk with your doctor. I know I spoke to, there's a doctor called Dr. David Chan who is in Sydney, and I heard him say that you should only drink really good wine. So I think that's quite good medical advice, but you shouldn't take that as gospel for you. Talk with your health professional. And yeah, if you're going to have a drink, really enjoy it if you've been given permission, because, gosh, there's enough very serious, horrible things going on in life. If you can enjoy that and that's your thing and it's okay, then yeah, just enjoy it. Lemon juice. Someone asked about lemon juice in water. They've been told that helps liver function. We have no evidence to say that liver juice, oh gosh, what an awful thought. Lemon juice helps liver function. So when I did a Google search on that just this morning to make sure of what the current research is, there are a lot of people talking about it, but they are not evidence-based scientific research kind of peer-reviewed papers. They are sites that are promoting all sorts of interesting and varied treatments. Now, it's not to say we might not find out in 5 years' time that actually lemon juice is great for your liver. But I think the really important thing when we're looking at these kind of complementary therapies or diet-based things that we think might help us is that the first thing, really importantly, is to make sure it's not doing us any harm. Because the last thing we want to do is to take something into our bodies with the intention of helping our body and actually making it harder for our body to deal with the cancer and the treatment. Now, there is some very interesting evidence around citrus juices and fruit juices in general and interactions with medication. There's more evidence around grapefruit juice. And I remember my background's actually in HIV nursing 25 years ago. And we were actually giving people a little medicine glass of grapefruit juice with their antiretroviral therapies back then, because there was this sense that would increase the absorption and the efficiency of those drugs. We stopped doing that really fast because the side effects were terrible. So it's really important to know that what you eat and what you drink can actually interact with drugs just as much as taking another drug. So just like you wouldn't take ibuprofen and Voltaren because they're the same type of drug and you'd be doubling up, you actually, for most people, taking a fruit juice at the same time as taking medicine is actually advised against by most of the medical websites that I'm reading up on. So as I said, there's more evidence around grapefruit juice, and I can share some links that have got some specific drugs and the way they interact. A lot of immunotherapy drugs, particularly, I noticed. So yeah, if you're taking juice, don't take it with your medicine. A bit of lemon juice in some water, if it makes you feel good in the morning and you're not having it at the same time as your medicine, it's fine. It's great. If you like the taste, go for it. But we don't have any evidence that that works in terms of liver function or fighting cancer. The other thing that I just really wanted to end on, and I guess we're probably talking about this most weeks, is just this, dealing with anxiety, and especially at this time. It's so tough. I was listening to a podcast, and this won't be everyone's cup of tea. Not everyone's into podcasts and not everyone's into American accents. I'm certainly not most of the time, but I have actually come across a researcher who's a social worker from America. Her name is Brené Brown, and she has just launched a new podcast. So I had a listen, and in the first episode, I'll post a link to it. I'm not endorsing anybody, but, I found it interesting. And she was talking about COVID-19 and how stressed everybody was about it. And she's talking about this concept of, she calls them FFTs, which stand for florid first times, can I say, or fruity first times, or not fantastic, unfantastic. You can work out what the F word is, but effing first times. For most of us, this is the first time we've done cancer, and for some of you, it's really early on in that experience. So you're learning a whole heap of skill sets. You haven't done this before. It's like working out a new language. You've been dumped in an unknown country. You don't know the language, and you've been told to go and navigate the public transport system. And it's like, what the? Not only that, at the moment, is that we're all doing COVID-19 for the effing first time, and it makes us really anxious. And so it's normal to be questioning yourself, to be feeling unconfident about this. It's actually normal for your health professionals to also be kind of working it out as they go along, just like we are, working out, well, what's the best way to respond? How do I drive this? How do I do this street? How do I get to this station now that I can't, do whatever? So I just wanted to normalize that and just go, yeah, cut yourself some slack. It's okay to be feeling like this. You're not doing a terrible job just because you're effing freaking out a little bit. It's normal to be frightened. We're here to help. The things that we know will help each person will be different for each person, but some of the things that are kind of fairly generalizable are things like, and I talked about this last week, about eating well, making sure you don't drink too much of the red stuff or the bubbly white stuff, talking about your feelings, trying not to bottle them up if you can, using each other, so jumping in the Facebook group. We've talked about just sort of tidying up some of the COVID-19 general content just to sort of give ourselves a break, which is really important. So maybe it's about just turning off the news and giving yourself a morning burst and an afternoon burst rather than it being on all the time, because our adrenaline system just won't cope with that. The other thing that some people, or certainly exercise, getting out. There is no law against going for a walk. At the moment, thank heavens, we can all still do that. And while the weather's not too wintry, that's a great opportunity if you can get outside, whether it's laps around your backyard or whether it's going for a walk down into your parklands if you've got it nearby. But yeah, we can all go for a walk. Make sure you wash your hands, coffee into your elbow, social distancing, all of that stuff that we all have had drilled into us. The other thing is meditation. So for some people, meditation's actually making them feel worse. So don't worry if it's not your thing, but it's worth giving it a try. And I'll post a link actually to a relaxation meditation. And I'm sorry, I'm always banging on about Cancer Council, but I see no need to replicate what they do really well. And they've got a fantastic relaxation meditation file that's on their website that you can easily download and give it a try. There's also one for sleep. So I know sleep's hard for lots of people. So I'll put the links up. So I'm just looking through. Thank you, Judy. Put the link up to Brene Brown. You're a legend, Judy. And I did see something there about pulse oxygen, so checking your pulse oxygen, and it's way up in the comments. I'm sorry, I'm looking through the bottom of my multifocal, very daggy glasses. Drew said COVID-19 attacks lung tissues. Using a portable pulse oximeter to measure your oxygen levels every day might help us monitor our own respiratory health if worried about COVID-19 exposure. It's a really interesting comment. That was Drew who commented that. I think one of the things that we've got to be really careful of is that self-vigilance can be a double-edged sword. And so if you're not feeling unwell, taking your temperature five times a day might actually not help your anxiety levels. So, and I'm not talking about, obviously, Drew, you're talking about checking your oxygen levels. My gut feeling is that probably you're going to notice feeling short of breath before it comes up in your oxygen levels on a pulse oximeter. I was involved in a clinical trial using pulse oximeters actually about 20 years ago. The evidence at that point on the portable ones was that the data was really pretty patchy. So the reliability of that as a measure of how your lungs are actually functioning wasn't really fantastic. And for the trial that I was involved in, we had to get really sort of close testing done of our equipment to make sure it was actually giving us an accurate reading. So there's some reasons why people might have a low pulse oxygen and yet their lungs might be working okay. And one of them might be just that they've got a chronic lung condition that might mean that it's always running a bit low. Sometimes if you're cold, your blood circulation in your fingers isn't as flush, or if you're old, or if you've got Raynaud's syndrome. So there's other things that can affect that pulse oxygen level. And I would probably if you ask me whether it's worth buying a pulse oxygen monitor, I wouldn't bother. If you've got one at home and it makes you feel better, you feel less anxious when you do that every day, then okay. But if you do it and you test it and it's like sitting on 92 or 93 and you're thinking, unless you're short of breath, I wouldn't be too concerned. We're more worried about people's temperatures and a dry cough with COVID-19. And if you're sort of physical distancing, keeping your hands clean, not coming into contact with other people, then you're probably at a fairly low risk at the moment. The community transmissions, it's building. We certainly need to be very careful when we go out in public, but that's a better measure, doing a temperature if you need to. And being aware of your body and the way it's feeling. So am I feeling short of breath? If I'm feeling short of breath, I take a temp. If that's up, then certainly get in touch with your doctor. The other thing I was just going to say was around appointments. So a lot of people are trialing telehealth. A lot of health professionals, telehealth this week, it's their effing first time. So you're probably going to have doctors who are a bit more anxious as well as us. So, we're all in this together. I had a comment from Donna. She just sent me an email before going, it was even harder than usual to think of all the questions that she wanted answers to because it felt even quicker and shorter, and probably a health professional was a little bit stressed as well. So the strategies around writing your questions down, checking if it's okay to still use your voice recorder on your phone if it's if you can do that, if you're not doing the telehealth consult on the phone that you want to record on. But if you're using a computer and you've got a telephone, like a mobile phone, using the voice recording, asking their permission first, but asking if they can record. Having someone with you in the telehealth consult so they can listen as well, and you writing your questions down. But also some doctors are actually really happy for you to email them with questions for the next visit. Often asking lots of questions and getting a to and from conversation is tricky, but you can often email them the questions for the next consult so that they kind of know what's on the table. There's some other strategies for communicating via telehealth, but bear in mind this is a huge learning curve. It's the effing first time for your health professionals, so they're not going to be expert at it either, and we're all doing this kind of huge learning curve together. I think it will get easier. Certainly for me, when I started working with people just over the phone and by internet, I had to learn. It looks like I had to relearn how to listen because I couldn't I couldn't touch people. I couldn't tell them that I cared for them because I couldn't touch their arm quite in the same way. I couldn't feel the temperature of their skin. I couldn't smell their breath, which sounds gross, but it's what us nurses do to help assess how people are. So it's about honing a whole new skill set for your health professionals. And so the more that you can tell them about what they might experience if they were in the room with you, that might actually help. At least with telehealth, often they can see the colour of your skin, which is great. But, you know, if you've got a temperature, you're going to need to tell them. If you've got pain, certainly tell them. And yeah, they're learning too. So I would be interested in people commenting about their tips for working with stressed out health professionals who are using telehealth for the first time. Other tips, other websites that you're finding helpful, pop them in. We'll talk about them together through the week. And next week, Facebook Friday will become Facebook Thursday because Facebook Friday is actually Good Friday, and I'm going to try and turn the computer off if I can for a while. So questions in by next Thursday morning, and I'll see what I can do about answering them. It's been lovely to chat with you all, and look, I just really hope you all manage to stay well. For those of you who might be quitting smoking, because we know smoking and cancer together make COVID-19 a really pretty horrible reality, good luck. I hope you're not going through too much gum, and take care. We'll talk to you soon. All right. Bye-bye, everyone.